Good evening to all of you. My name is Dr. Vidyadhar Watve. I am a consultant psychiatrist at Pune Hospital and Research Center for last 40 plus years. I am exclusively in private practice, although I had an experience of working in Mental Hospital Yeroda, Sassoon General Hospital as a visiting doctor, and then again I was attached to a couple of rehabilitation centers. I am a past president of the Indian Psychiatric Society during the year 2015 and 2016. I am member of Indian Medical Association, Indian Association of Epileptology, Indian Association of Suicidology. I have got a couple of publications to my credit, and my main uh, thing that I like is to talk to people, and I'm involved with Dr. Vihan Bhaiya in giving a couple of talks on scientific subjects in various national and international fora. With this, I think I'll start with the main topic, that is discussion on bipolar disorder. Friends, bipolar disorder is a type of mood disorder characterized by alternating moods of depression and mania, often with normal mood in between. Depression may cause feeling of sadness, worthlessness, hopelessness, and even suicidal thoughts. Mania, on the other hand, may cause excitability, rage, and racing thoughts. The mood changes may be dramatic and abrupt. They'll come just out of blue. Untreated bipolar disorder can have problems with interpersonal relationships, working, academics, and it may sometimes lead even to thoughts of suicide. Bipolar disorder is a treatable disorder, and people with this disorder can have normal, happy life if they are treated well and maintained well. Few signs and early signs of bipolar disorder. Friends, the first signs and symptoms of bipolar disorder are varied. Many of these symptoms can also be caused by other conditions like anxiety disorders and other many psychiatric disorders, including schizophrenia. So that may really create a problem in diagnosis of this disorder. The signs of bipolar disorder can generally be divided into those for mania and those for depression. 7 signs of mania. I always put it like that. Although there are several signs, but the 7 most important are: 1. For mania, feeling very happy, unusually high for long periods of time. Having a decreased need for sleep. A manic patient will not need 6 hours, 8 hours of sleep. He may get up and all fresh after 3 hours. Talking very fast, often with racing thoughts. Feeling of extremely restless and impulsive. That is a sign of mania. Becoming easily distracted. It's very difficult for a manic patient to control or to concentrate on a particular thing because he's highly distractible because of the illness. Becoming easily distracted is a hallmark. And then having overconfidence and self abilities. मैं ये भी कर सकता हूँ, मैं कुछ भी कर सकता हूँ, and engaging in risky behavior because of all this, such as having impulsive sex, gambling with life's earnings, or going on high spending sprees. 2 लाख का माल खरीदो, कार्ड यूज करो, ये स्वाइप करो. This can all happen in a manic phase. These are the 7 important signs. Friends, important to remember, all this can have mood congruent or mood incongruent psychotic features. I'll explain this in little detail. What I have told you is signs of pure mania. Mania is a mood disorder, I have told you. Psychosis is a different ball game. When there are presence of delusions, hallucinations, and disorganized behavior. But the fun is, even a case of mania can have mood congruent psychotic features. So mood plus psychotic features is mood congruent psychotic features, or patient can have mood incongruent psychotic features. Nothing will be true what he is explaining as his ability. So it's not related to mood. Most of the time it will be mood congruent. I'll say my ability is this, I'll go ahead and attempt so many things. So this is mood congruent because I feel somebody's telling me to do this. Somebody's telling in my ears that go Dr. Watve, go and buy this and you will be lucky. So this is mood congruent psychotic feature. Coming to 7 signs of depression. Friends, like mania, depression can have some other illness, depression can be present in some other illnesses also. But there are 7 important signs of bipolar depression. Number 1, feeling sad or hopeless for long periods of time. Friends, sometimes you feel low. In the Indian cricket team loses a match, you feel low for that day. But feeling low mood and sad for extended period, for a very long period than normal, is a sign. Withdrawing from friends and family. फैमिली से मैं बात नहीं करूंगा, दोस्तों से बात नहीं करूंगा. आई एम विड्रॉइंग फ्रॉम द फ्रेंड सर्कल and family environment. Leaving interest, losing interest in activities that you once enjoyed. It's called as anhedonia, inability to have pleasurable sensations from usually pleasurable things. It's called anhedonia. Like good music can give you pleasure, good food can give you pleasure, but a depressed patient unfortunately cannot enjoy all this, and we call this anhedonia, inability to have pleasure. Okay, then feeling severe fatigue and lack of energy, having significant change in appetite. In depression, generally people feel it will be always no appetite or low appetite, but in an atypical feature of depression, patient can have excessive appetite, patient can have excessive sleep. These are the atypical features of depression. Having problems with memory, concentration and decision making, because I am involved, because the depressed poor guy is involved in his own thoughts, which are there are thoughts of hopelessness, helplessness, suicidal thoughts. I am not able to concentrate. As a result, I am not able to memorize. Because the registration is poor, this poor guy is not able to memorize and reproduce when needed. Thinking about or attempting suicide. This is very, very important, and people should take it really seriously. You never say barking dogs never bite. No. See, in a depressed patient, the suicidal ideation, expressing suicidal ideation is a cry for help. Please don't neglect it, otherwise you will lose a patient, you will lose an individual, you will lose a precious life. Take it very seriously. There may not be direct sentence that I'm going to commit suicide, I'm fed up with life, but there will be something which will suggest that he'll go and buy a bottle of T20, he'll go and buy a robe. He will be just doing something which you should be watchful, so that you can avoid 100% reversible problem. Depression, in my opinion, is reversible. You can treat it with medicines, which I am going to discuss later. Again here, depression can be with mood congruent psychotic features or mood incongruent psychotic features. For example, Dr. Watve, I am feeling hopelessness, helplessness and sad. But when I get out of the house, I feel people around are talking about me and they are saying, what a useless fellow this Dr. Watve is, not practicing, just roaming about. I actually hear people saying that people are making fun of me. They are passing remarks against me. This is mood congruent psychotic features. Friends, again I want to emphasize, you cannot have watertight. Depression is a mood disorder, psychosis is schizophrenia and the other psychotic disorder. There is an admixture. People can have depressive features, elation features in schizophrenia. People also can have psychotic features in mania as well as depression, which I have discussed a minute ago. Then, what are the challenges of the bipolar patient that is not talked about? What is not discussed, that I am going to tell you. Fleeing friends. The friends, they don't remain attached to you. They run away from you. Because they are fed up with previous experiences of a manic phase or depressed phase. Fleeing friends. Friends going away is an important thing which caregivers should keep in mind. Suffering self-esteem. These people, they always feel, manic phase always feel that they are on the top of the world, but here they are lacking the self-esteem. Best way to do is you ask your two or three friends to write down about what they feel about XYZ, Dr. Watve in this case. If I'm a patient of depression or mania, let your friends write down what is their observation about my mood and my confidence or otherwise. And just compare that with whatever you have in your mind or whatever you have jotted down. So this is the best ways to find out what about the suffering of the self-esteem. You are suffering from the self-esteem, but you can really find out from the friends who are writing it down for you and discussing with you. The next is rough relationships. It's best to be honest and transparent with your significant other. And don't forget that your partner also has some needs. Discuss with your loved ones, discuss with your partners, and that will avoid the problem with interpersonal issues and indirectly these rough relationships. Then what are the challenges caregivers face in caregiving patients with bipolar disorder? As you know, in every psychiatric disorder, there is something called caregiver's burden. Schizophrenia lasts for ages, decades, not ages, but decades certainly. It's a recurring and relapsing illness. Unipolar depression, also recurring, relapsing. Bipolar depression, more so recurring and relapsing. So these are the challenges which caregivers are facing. Now, what are the challenges? Basically, diagnosing the disease. You know, one of the big challenge in dealing with bipolar disorder is recognizing both the depressed phase and that of mania. Make sure your doctor understands that you are experiencing both these ups and downs so that treatment regime prescribed to you will cover the full spectrum of your symptoms. Discuss with your doctor. Let me tell you, even if you say my interviews here, please let me share with you that I am really experiencing highs and lows. So it's giving a hint to the treating doctor. So that is very important. Addressing addiction, very, very important. It's common comorbidity in many psychiatric disorders. Schizophrenia can have alcohol addiction, nicotine addiction, ganja addiction, and whatnot. In obsessive disorders, patient can have addictions. In bipolar disorder, depression, as well as mania, people have addictions. Common in our country is alcohol. These days, more common in younger guys is cannabis. You see people, celebrities in Bombay, suffered from depression and now she took to ganja. So that ganja, she was not a ganja peddler, but she was a ganja user. She was a poor victim and she had to take it because ganja for some time used to give that he or she a little high. So keep watching that. Don't say that let me treat depression first and then we will address addiction. No, you have to address both the things enthusiastically and simultaneously with all the medicines and all the armamentarium of psychotherapy or medicines that you have with you. Then finding the right medication. There are many, 15 different medications available. So you have to choose, you selective what suits best for the patient. If nothing is working these days, you can have the genetic testing done. So people will know who are the fast metabolizers and slow metabolizers. So on that, you can adjust the dosage. Coming to the most important question, how bipolar disorder differs from unipolar disorder. You see, bipolar depression is same as depression of unipolar depression. But very important that they are both categorized as mood disorders. Bipolar disorder as well as depressive disorder, both are mood disorders. The Latin prefix uni means single or one. The Latin word bi means both. Correct. So with both these affixes, unipolar or bipolar will tell us whether it's a recurrent depression. Depression can come again and again and again after a gap of 1 year, 6 months, 2 years, or whatever. See, bipolar depression will have highs and low. More high and more low is bipolar. More low but less high is bipolar 2. We'll not go into the subtypes of bipolar 1, 2, 3, etc. Unipolar depression depicts that moods are centralized around one depressive pole. It's unipolar. So whatever symptoms you get will be symptoms of same depressive episode which you had 10 years ago, which you have 5 years ago, and which you have 2 years ago, which current episode is. Very important, I had a patient, and it's known and it's described in literature that every unipolar disorder, depression, is a potential bipolar depression. So I had a patient for 20 years, she showed only depression, unipolar. And only on one day, she just started flying high. So that was the first episode of mania in that case. And since then, she's having regular cyclical changes of mood changes. What is the cause of this? Most of the doctors have told you that it's a brain chemical change. It's not only brain chemical changes, but it's genetics, environment, and all this leading to change in brain chemistry, which can be treated with another chemical, namely medication. So it's all a biological disorder. Although role of psychological or social therapies is very much there, which I discuss in the end. What are the medications? Number one, mood stabilizer. This word mood stabilizer is not accepted by many in the world now because there is nothing such as mood stabilizer. Our MS Reddy from Hyderabad says, as a rule, bipolar disorder is a treatable disorder, and as a rule, bipolar depression is a recurrent disorder. You can treat it, but you can have. As a rule, it's a relapsing disorder. As a rule, it's a treatable disorder. That's what MS Reddy from Hyderabad always says. So, mood stabilizer, there is definite role. But there are a couple of differences between the opinion of Western people and American people. American people will always treat, if you confirm bipolar, they will treat only with mood stabilizer. Whereas Europeans, they always guide us to use antidepressants in bipolar disorder under cover of a mood stabilizer. Mood stabilizer, all anti-epileptic drugs are mood stabilizers. Currently, the newer atypicals like quetiapine, ziprasidone, olanzapine, risperidone, they are also taken as they are treated as a mood stabilizer. And under that cover, you can give antidepressant drugs. But this is more of a European view rather than American view. Come what may, they will not use antidepressant. But in our country, where we want a breadwinner who is unwell with mania, we treat it even with haloperidol injectable under cover of either lithium or other mood stabilizer. It's a practical approach that Indians, or I always take. Then antipsychotics, I told you. Atypical antipsychotics, they do have a role, and quetiapine especially is now FDA approved somewhere in 2017 or 2015 as a mood stabilizer. They use quetiapine up to 200, 300 milligrams as a mood stabilizer. So, basic medication, antidepressant, mood stabilizer, and atypical psychotic. I use even typical agents to control mania. And last but not the least, I use electroconvulsive therapy very regularly in many patients when their mania is not under control, or their depression is not helping, or there is suicidal depression, or there is a depression with mood congruent or incongruent psychotic features. So ECT is most important treatment which I use. People have different opinion, that's a different thing, but I use it successfully for the last 40 years. So is psychopharmacology the only way to treat bipolar depression? No, sir. You have psychosocial therapies. You have basically psychoeducation. When the patient comes to you, please see that the family and the patient, both of them, are properly educated about the cause of this disease, about the long-term prognosis of the disease, and about the care that they have to take of their near and dear. And patients are supposed to keep a mood log. Mood log. They should keep a mood log and write down what was my mood today, what was my mood was yesterday, vagara vagara. So this is very simple thing. For an educated bipolar, they can definitely keep a mood log, and which will help. Then comes interpersonal and social rhythm therapies. I think I always have the maximum faith in psychologists who are trained in cognitive behavior therapy, who are trained in psychotherapy. And I have two, luckily, I am lucky because I'm in a metro. I've got two MPhil and PhD psychologists who are helping my patients with psychotherapy. Because whatever, in a small place, I know you cannot get even a psychologist, leave aside CBT specialist or neuropsychologist. You have to learn yourself. But if you are going to do it, please learn it when you are attending all the seminars. Attend the seminars organized even by the psychologists. Take a proper training and you can solve. You see, it's not only psychologists can do, we can also do. But definitely if you are trained, then only put your foot there. Right? So that's my friendly advice. Then family focused therapy. And finally, cognitive behavior therapy is also extremely important in managing bipolar disorder. So, I've told you what is bipolar disorder, how it is different than unipolar depression, their etiology, and the medications that use, and finally, I've told you the importance of our psychologist colleagues and their role in psychotherapy. And on day one, I think we should plan not only the prevention and treatment of further attack or treatment of this episode, but you should plan for rehabilitation. Right on day one, you should plan for rehabilitation, and your aim is to see that patient is back in the mainstream and is earning his livelihood to the best of his capacity. Thank you very much.